Alaikum wa rahmatullahi wa barakatuh. Dear friends, colleagues everywhere, welcome to this joint meeting of Emirates Cardiac Society and Emirates Neurological Society. And it's great to have Dr. Suhail Al-Rukun, is the president of the Neurological Society of Emirates, with us, and myself, Abdullah Shihab, from Cardiac Society. We have really agreed to or decided to have something together. It's going to be three sessions together. So today we'll be fighting stroke, focusing on atrial fibrillation. For that, I'm going to introduce the cardiology member, then Dr. Suhail will introduce the neurological member. So for cardiology, we have Dr. Hani Sabur, is a cardiology, consultant cardiology, electrophysiologist from Cleveland, Abu Dhabi. Great speaker, educator in the field, and he will take us through how we can fight, stroke from atrial fibrillation point of view, from cardiology point of view. So, Dr. Suhail, maybe you want to also welcome others and you introduce the speakers.
Excellent. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Welcome all our friends, delegates. It's my honor today to be co-chair this webinar with Professor Abdullah Shihab. Stroke is one of the life-saving worldwide issue. There's more than 5 million death because of stroke and more than 10 million global stroke disabled patients per year. This is a huge number, and making this awareness is very important. Today we'll have two of our distinguished speakers, Dr. Abdullah Shihab, welcome Professor Hani. I will welcome my friend and colleagues, Dr. Syed Habib Kamran. Dr. Syed is a specialist neurologist and he's a fellow of cerebrovascular disease and stroke. He did his training, neurology and fellowship at Aga Khan University. Dr. Habib currently working at Rashid Hospital. He's the chair of the stroke research program at Rashid Hospital, and he's the co-director of SITS International Registry at level of UAE. Dr. Habib is active in the stroke area and research in the field of cerebrovascular disease. And today he's going to speak about the atrial fibrillation. Welcome, Dr. Syed Habib.
Thank you very much.
So we're going to start with Dr. Hani, please.
Thank you very much to both chairpersons for this very kind introduction, and I wholeheartedly agree. This is a very, very important topic, and it's certainly part of cerebrovascular disease and cardiovascular disease are some of the most important and serious comorbidities. In fact, our belief is that the preventability of cerebrovascular disease is very important and often one of the major issues in management. So my focus today will actually be the cardiology perspective in Afib, and something a little bit different than anticoagulation, because I think that's fairly settled. We'll be discussing the idea of rate and rhythm control in atrial fibrillation. So our objectives will be to look at the management strategies for Afib control, when do you use rate and when rhythm control are important, and recent clinical studies that support ablation. So here's a fairly typical case, a 71-year-old lady presenting for checkup. She has a history of hypertension and obesity. She's found to have previously undiagnosed Afib with mildly increased ventricular rate. She's only on enalapril 5 and atorvastatin 10. So this is her exam. She's normotensive, heart rate's 125. She has an irregular heart rhythm. She's a little tachycardic. You can't really appreciate any murmurs, and fortunately no neurological signs. Here are her labs. You see the kidney function is normal. Creatinine clearance is 62. The hemoglobin is 12. White count's fine, and she's euthyroid. The chest x-ray is unimpressive. She had a normal coronary angiogram a year ago. Her echocardiogram shows normal LV function, but a markedly dilated left atrium and no significant valvular heart disease. So this is her ECG. So just to clarify, there are specific electrocardiographic features that confirm the presence of atrial fibrillation. So first of all, it is irregularly irregular, somewhat fast. You see in V1 and lead 2 in particular, you see these fibrillatory waves. This is not true atrial flutter because the cycle length is variable, the morphology is variable, and if you look in the other leads, you don't see the sawtooth pattern consistently. Now, 24-hour Holter monitor is done, and the heart rate isn't really too bad. The average heart rate is 98 beats per minute. The maximum is 161. So what would be the best treatment strategy at this time for this patient? So you initiate the NOAC of your choice, add bisoprolol 2.5, and repeat the Holter monitor in a couple of weeks. You initiate you initiate your NOAC plus amiodarone 200 milligrams daily. You initiate the NOAC and arrange for a TEE-guided cardioversion, and then use sotalol or some other antiarrhythmic drug after the cardioversion for maintenance of sinus rhythm. Or do you initiate warfarin and give chemical cardioversion with flecainide and maintain flecainide if the cardioversion is successful, or some other strategy? So, so there's also no completely right answer here. But of course, in terms of stroke prevention, this is a female patient who's over the age of 70. She has hypertension and left atrial dilatation. So obviously, this is a patient who is going to require long-term anticoagulation because of her CHADS VAS score being at least 2, not including female. Now, the other point is, isn't it also important to look at the maintenance of sinus rhythm and heart rate? So if you abandon rhythm control, which would be choice B or choice C, then you're only going to give this patient the opportunity for worsening LV function and increasing left atrial dilatation, and probably even the development of heart failure with preserved ejection fraction. So there are certain benefits of rhythm control, which we will discuss. In general, we do not initiate direct cardioversion unless the patient has had 4 weeks of pre-cardioversion anticoagulation or a transesophageal echo concluding that there's no evidence of thrombus, and then you can proceed with your cardioversion. Now, I'm going to change the case for you a little bit. And let's say this patient is actually 45 years old with minimal exertional dyspnea. And the echocardiogram shows mild LV dysfunction. The left atrium is also big, but the EF has started to drop. And there is some mild volume overload. So now the heart failure is associated with the LV dysfunction. So when would that change your outlook? So again, would it be anticoagulation and beta blocker only, anticoagulation and amiodarone, anticoagulation cardioversion, and then sotalol or some other antiarrhythmic, or flecainide? So one of the important points to remember, which antiarrhythmic drugs are contraindicated in a patient with heart failure, with LV dysfunction? Is it amiodarone? Is it sotalol, flecainide, or propafenone, right? Or is it a combination of C and D? So typically when the patient has significant heart failure, clinical heart failure, remember that flecainide and propafenone are 1C sodium channel blocking agents and are not recommended in patients with LV dysfunction or with significant coronary artery disease because of the results of the CAST study, where this led to increased mortality. So let's look at AFib management in general. So I think all of us are familiar with anticoagulation. We all know the CHADS VAS score, and we're very familiar with that. But you also have to look at the risk factors. Why did the patient develop heart failure? Why did, atrial fibrillation? Is it heart failure? Is it electrolyte imbalance? Is it coronary artery disease? Is it valvular? Is it something else? Is it sleep apnea? Rate control is also very important, as is rhythm control simultaneously, and also discussion with the patient about all of these pillars. So what has the data been for rhythm control since 2019? There's been a couple of very important clinical studies. And why do you need to do rhythm control? Is it improved quality of life, longer life, mortality, morbidity, and how do you do that? So there are many antiarrhythmic therapies, amiodarone being the most frequently used, but we also have sotalol, dofetilide, flecainide, propafenone, and quinidine. The problem is these medications all have a lot of toxicities and require a lot of, therapeutic drug monitoring. Also, don't forget that beta blockers are also antiarrhythmics as well as calcium channel blockers. However, since 1998, the French group in Bordeaux, Heisaguer and his colleagues realized that a lot of the atrial fibrillation initially starts from inside the pulmonary veins. So these pulmonary vein foci can be ablated or isolated from the left atrium. So here are the two right-sided pulmonary veins. You isolate them using balloon or radio frequency, and you do the same thing for the left-sided pulmonary veins. And that reduces the likelihood of Afib being conducted into the heart. So older studies included Affirm, looked not at ablation, but looked at antiarrhythmics, right? So the Affirm study was from 2002. Again, these patients were having Afib with some degree of heart failure, and rate control actually had lesser mortality than rhythm control. And the reason why this happened was the use of fairly toxic antiarrhythmic agents. So this is the point that, in fact, rhythm control is not a negative for all patients because that study did not look at ablation. So in reality, there was a non-significant difference in all-cause mortality. However, in patients who were given sinus rhythm, the increased risk was due to the antiarrhythmic therapy. So we really have to consider what's the next step. So where many patients do not actually fulfill this criteria, young patients with lone Afib, patients with reversible Afib, for example, thyrotoxicosis, post-CABG Afib, also patients with SVT or WPW, that Afib is a result of the rhythm substrate, and patients with tachycardia-induced cardiomyopathy and severe sleep apnea. So as you obviously realize, atrial fibrillation is a disease of the aging patient. So by the time patients are 75 to 80 years old, the risk in the US population is significantly higher, almost threefold higher as well. Now, we don't have a lot of data on the younger patients. So one of the most important clinical studies that I mentioned to you, which was released about 3 years ago, was the Cabana study. So the Cabana study looked at ablation versus antiarrhythmic therapy on 3 endpoints: mortality, stroke, bleeding, and cardiac arrest in patients with Afib, as well as quality of life. So the really important, robust cardiovascular clinical endpoints. They had 2,000 patients that were initially randomized, 1,000 to ablation and 1,000 to drug therapy. The problem is there was a huge crossover. A lot of patients who were in the medical therapy arm actually went to ablation, almost 30%. And in the ablation arm, 100 patients refused to have an ablation. So again, there's a lot of crossover, so you can't really draw a very critical conclusions here, but this does represent a lot of patients that you see in clinical practice. There were a substantial number of patients with an age less than 64, a lot of men, but also a lot of women. The heart failure was seen in about 35% of patients. Almost everybody had LVH and hypertension. Diabetics were a quarter, sleep apnea and coronary heart disease were another third, and the history of stroke or CVA was about 20% of these patients, with a variety of CHA2DS2-VAS scores, but the average was about 3. Here, it's very clear that compared to drug therapy, there was a difference in terms of catheter ablation. The catheter ablation was 14% less of overall events, although the p-value was not statistically significant. When you looked at all-cause mortality, they were almost the same. However, if you looked at hospitalization and mortality, there was about a 20% reduction. Now, the freedom from atrial fibrillation was higher in the Afib group, a more robust 50% reduction. But of course, you had to have ablation for that to happen. So when they went back and reanalyzed the patients, whether they did have ablation, and some of them, as I mentioned, did have ablation in the control arm, and there were a lot of patients in the drug therapy that did not have ablation. When you actually took them into what was actually done, actual procedures done, those patients who received ablation had a 27% reduction in hazard ratio, and those patients at 6 months and 12 months remained the same. So this is really telling us that the primary endpoint is being achieved if you actually do the ablation. So when you finally take those patients, the quality of life score was significantly improved compared to medical therapy, and the severity, frequency of Afib recurrence was also reduced as well. So a fairly important concept here is that drug therapy, which we knew from the old Affirm study, compared to ablation therapy, is not the same. It's certainly inferior in terms of quality of life and certainly in terms of the hard outcomes. Now, the important point to remember is that if you actually had ablation, mortality and hospitalization was reduced and 50% reduction of recurrent AFib. So drug therapy is in fact less effective when ablation was done. So it's clearly an acceptable treatment strategy in patients and to lower event rates. Now, a more important clinical study, I would say, a very precise clinical study, which really looked at a very defined group of patients, was the Castle AFib study. So here they looked at catheter ablation in patients with AFib and heart failure. And as you know, the use of antiarrhythmics in heart failure patients is quite limited. And here there was a big difference. There was a very large difference that started very early in terms of from 12 months to 60 months, and almost 40% reduction of hospital admission and survival. Death from any cause was also reduced by about 50%, and hospitalization was 50% if you received ablation compared to antiarrhythmic medical therapy. So significantly lower composite endpoint of death from any cause or hospitalization for heart failure than with medical therapy. So this has led to catheter ablation being elevated in the guidelines in patients with symptomatic AFib and heart failure with reduced ejection fraction to lower mortality and reduced hospitalization as well from the clinical study. So when you're looking at a patient with AFib, it isn't just anticoagulation. It is also about, do we go to rhythm control? Do we go to rate control? So some of the clinical features that are helpful, which come from the Canadian guidelines, patients with paroxysmal or recently onset AFib, they benefit from rhythm control. This is an earlier stage of disease. The atrium has not remodeled. If they're less than 65, they have more symptoms. If they have heart failure, and if they're de novo, they have not failed antiarrhythmic therapy. So those patients benefit from rate control, rhythm control, and we have a lot of patients like that in the UAE. Older patients with long-standing AFib, big dilated atriums may not benefit as much. No history of heart failure, failed antiarrhythmics may be the patients who benefit from rate control, rhythm control. So I think this is an important choice that you have to think about, but no person is actually excluded from the possibility of ablation. So remember, the younger patients, the paroxysmal patients, the patients who are recently diagnosed with AFib, certainly patients with heart failure, certainly patients who have not failed antiarrhythmic therapy can be maintained in sinus rhythm better. So this is really how you should approach patients in symptomatic AFib. So initially, you're going to add your anticoagulation. You will attempt early rate control until you are going to get to the point of TE cardioversion. Now, if the patient has more symptoms, more recurrence, increased worsening quality of life, or they have cardiomyopathy, worsening LV function, HFpEF or HFrEF, right? At this point, you have to consider using antiarrhythmic therapy to control the rhythm. If that's not working, then ablation will be a very good early first step. So when you do rhythm control, clearly, and we have seen this in a lot of our patients, fatigue, palpitations, and heart failure symptoms are significantly better. With ablation, they may be more able to respond to antiarrhythmics. So we have patients who didn't respond to antiarrhythmics before. Now they are completely responsive to antiarrhythmics and they have very little recurrence. You return the atrial syncope and atrial contraction. And clearly, in terms of LV function, there's a big advantage. You could consider rate control in patients who have had multiple antiarrhythmics or side effects, particularly from amiodarone as well. So there's no specific single strategy for AFib management that is suitable for all patients. You have to individualize. And rhythm control since 2019 is very different compared to rhythm control in 2002 because of the efficacy of ablation has been shown in Cabana and Castle AFib. And patients have to make this decision in conclusion with the doctor. So here's a case to wrap this up. This is a 62-year-old gentleman who is apparently asymptomatic. As you see, the patient has a QRS that's narrow. This is obviously irregularly irregular with fibrillatory waves here, and heart failure as well. So because the patient has a narrow QRS, Crt device is not indicated. So is a patient with AFib truly asymptomatic? So if the patient has atrial fibrillation that has caused the ejection fraction to drop, You can't really call it asymptomatic because it has a biological effect. And as you see here, in those patients who had asymptomatic AFib but worsening LV function, the survival is significantly less. So this patient underwent a cardiac MRI. As I mentioned, his ejection fraction is 30%. He has persistent AFib. There is biatrial enlargement. And you can look at this and say, well, the likelihood of getting him back to sinus rhythm is low. In fact, one of the important points is left atrial remodeling is actually one of the beneficial features after pulmonary vein isolation. This is a patient pre-ablation and post-ablation, the ejection fraction improved and the left atrium actually became smaller after maintenance of sinus rhythm. Now, AFib doesn't fix all the points. It's an important therapy in many patients with AFib and heart failure. Asymptomatic patients, the symptoms will not be different. It doesn't prevent you from, you don't do the ablation to prevent anticoagulation. It's not one of the reasons we do it. And there is some benefit in persistent AFib, but chronic is probably unlikely. So let's look at a patient with chronic needing heart failure resynchronization. So resynchronization has to have several requirements. In heart failure, completely on medical therapy, wide QRS, when the QRS is more than 120 and the EF is less than 35% with functional class 2, 3, and 4 on medical therapy. So this patient will not meet this criteria, right? Because the patient's QRS is not wide, because the patient is not pacing. So I think it's going to be important to realize that we have to think about this. Why does atrial fibrillation make it more difficult in patients who have a device? Because if you have atrial fibrillation, you can have a rapid heart rate that prevents resynchronization. With atrial fibrillation, you lose the atrial transport. So there's loss of AV synchronization. And you see here, this is a patient with a biventricular, not our patient, with a biventricular pacemaker who has atrial fibrillation. And you see some of the QRS complexes are narrow and some of them are wide. They fail to do QRS capture, biventricular capture. So it really is important to try and give the patient sinus rhythm, particularly if they have a CRT device. And there are many studies that show that atrial fibrillation makes CRT biventricular pacing less effective than otherwise in sinus rhythm. So in these patients, some of the investigators in the past have actually done CRT with AV node ablation. So you leave the patient in AFib and ablate the AV node. And this actually has a significant improvement in the QRS complex and the pacing. So what is the benefit of a CRT device? It has to pace about 100% of the time for the function of the heart to improve. So this is really this particular patient. The patient had a CRT device. You see here's the RV lead. Here is the LV lead here on the left side. And post-implantation, the QRS is 138 milliseconds. With 138 milliseconds, that means you have achieved true electronic resynchronization. By 2013, the patient's 98% by V pacing. The EF has improved to 42%. The ventricle has shrunk, and the symptoms have gone from class 2 to class 1. So one of the important points to remember is that if you have patients with permanent AFib on pharmacological therapy, if the patient undergoes AV node ablation, CRT will be helpful because then you will have a wide QRS and you will have complete biventricular pacing. On the other hand, if they have the CRT and they do not have 100% biventricular pacing, then AV junctional ablation will be helpful. But now, as I mentioned, the other option, this is before the Castle AFib study, is a ablation as well. And with that, I will stop and turn it back to my co-chairs and my colleagues.
Recording in progress.
Thank you, Dr. Hani. It was a pleasure to listen to your presentation and to go through all these data that you shared us and how to recognize the AFib and what's new in the AFib. We will keep the Q&A till the end. I would like to welcome Dr. Habib, who's a neurologist and stroke specialist from Rashid Hospital. Dr. Habib is going today to update us and to take an overview about the atrial fibrillation and stroke, correlation, etiology, presentation, and also how to prevent this. Please welcome Dr. Habib. You can share your screen. Yes, we're waiting for you, Dr. Habib. Take your time.
Yes. Can you
We
hear
can
me?
see your screen. Yes, we can see your screen. Please, Habib.
Thank you. Hello, assalamu alaikum. Good evening, everyone. And thank you very much for this nice presentation by Dr. Hani. It was really informative. So today I will be discussing about the atrial fibrillation related to the stroke. And the atrial fibrillation is already discussed by Dr. Hani in detail, the different therapy for the rate control and the rhythm control and the new ablation therapy. But here I will be discuss about secondary prevention of the stroke in the stroke patients who have the atrial fibrillation. Because most of the patients, the burden of atrial fibrillation in the hospital are in the cardiology, but at the same time, in neurology also, we have a lot of patients who are coming with the atrial fibrillation with the strokes. So we know that these atrial fibrillations are mainly related to the higher age and comorbidities like diabetes, hypertension, ischemic heart disease, and so on. In our hospital, even in the Asian country, if you see the papers, we have seen that there are a lot of young patients are also coming with the atrial fibrillation and with the stroke. Even in our practice, almost every fourth patients who are less than 40 years of age or close to 40 years of age, they are coming with the atrial fibrillation related with the strokes. So that's why this is very important to know that how to diagnose, how to make awareness in the society, and then further management of these strokes. These strokes, usually atrial fibrillations, if we compare with the carotid disease or small vessel disease, they present with more big stroke, major strokes mainly, and mainly the cerebral infarctions as compared to the retinal infarctions. This is 25:1 as compared to the carotid disease, and mainly they have embolic bilateral stroke or big cortical strokes. So sometimes radiologically also we can predict that this patient has atrial fibrillations or some cardio embolic strokes. So for the management of the stroke in atrial fibrillation patient or for the secondary prevention, the most important is the public awareness. Because if the people will know that what is atrial fibrillation and these things, so they can take care of this, then risk stratifications, which will also help that which patient needs to be treated, and then finally the selection of the medications. So we all know about this scorings like the SHAD score, SHAD2 score, congestive heart failure, hypertension, usually this 140/90 millimeter of mercury, or if the patient is already treated or is on medication, then also we give 1 point, then age 75, diabetes, then of course a stroke. So 2 or above 2 patients we select for this anticoagulation. Then this is a SHAD score. Here we can add the vascular disease for 1 point, age 65 to 74 1 point, and sex female, so it's additional 1 points. Hasbled score also we follow the Hasbled score just to see the side effects of the medications, predict that which patient will get more benefit to assess the risk versus benefits. So what we are talking about, that what are the different strategy or medications which we can offer for the secondary preventions. So here we all know that we have injectable enoxaparin, calaxane, which are vitamin K antagonist. We have warfarin, vitamin K antagonist. We have clexane, warfarin, clexane and enoxaparin. And then we have direct oral anticoagulants, in which we have dabigatran, we have apixaban, rivaroxaban, which have the different mechanism of actions. Dabigatran is thrombin inhibitor, while others are apixaban, and this rivaroxaban is direct 10A inhibitors. So different drugs have different mechanism of actions. So how do we know that which medicine is superior, whether this is warfarin or oral anticoagulants? Because the selection of the medicine is very important. In 1995, before 1995, we had no much choices, so aspirin was given, but later on it is found that warfarin is much better than the aspirin, and almost 2/3 of the strokes are prevented by the warfarin. Then later on in early 2009, dabigatran Relight trial came. Then dabigatran was showed some improvement. It is non-inferior trial. Then later on, rivaroxaban and apixaban also showed this efficacy. So this direct oral anticoagulants or NOACs, they are better than warfarin in the sense that this is easy to administer. For example, rivaroxaban is a single dose. In these cases, no need to monitor INRs. Then the patients can easily tolerate these medications. There are no interactions with other medications. So it improves the quality of life, and it reduces the administrative costs or labor costs. For example, no need to come to the hospital to monitor the INR. But on the other hand, the same time in our subcontinents, it is little costly also, these medications. So in some patients who cannot afford, in those patients it is not really favorable, but as a whole this is favorable. Or sometimes for example, rivaroxaban and these medications have some renal patients, it is also difficult to give these drugs, but as a whole these are the favorable outcomes. So these are the trials which we will discuss about. We all know these trials. Number one is Relay trials, which is for the dabigatran. It came in early 2009. Then Rocket trials for rivaroxaban, Aristotle trials for apixaban, and then Engage for edoxaban. In Relay trial, it was in early 2009, and there were two arms. One is for 110 milligram, and another was 150 milligram. And you can see here that in both arms, it showed benefit over the warfarin to prevent the thromboembolism, stroke, or TIA. In the 110 milligram, it was non-inferior to the warfarin, and the hemorrhage was significantly lesser than the warfarin. And in 150 milligram, you can see that this one is from the prevention of the stroke point of view, it was superior to warfarin, and the hemorrhage was almost equal to the warfarin. In the Rocket trial also, we can see that it is also non-inferior to the warfarin in both in prevention of the stroke and in the hemorrhage also. From the hemorrhage point of view and both point of view, it was better. But in the Rocket trial, there were few more gastrointestinal hemorrhage also. We noticed in that trial. In apixaban, Aristotle trial also, apixaban also showed it is also non-inferior to the warfarin. In fact, it is better than warfarin in both cases. Less number of the ICH hemorrhages, and in the prevention of the stroke also, it was better than the warfarin. It was more efficacious. Then in Engage trial also, edoxaban also showed improvement in both doses, 30 and 60 milligrams. So in all these trials, patients had mainly, it was non-valvular heart disease, but there were a lot of patients with a mild to moderate valvular heart disease, like moderate to severe mitral regurgitation. You can see here number of the patients. were there in that study. Then mild mitral stenosis, moderate to severe aortic regurgitation, and moderate to severe aortic stenosis were included in all these trials because, sorry, just a minute. So there were a lot of mild to moderate valvular heart disease patients were also included in those trials, and so benefit was there also in those patients. So if you see here in the no valvular heart disease in Aristotle trial, it shows the favors the NOACs. Although the p-value was not very significant, it was close to the midline, but it favors. It is even in the engaged trial also edoxaban. In relay trial with the higher dose, you can see here significantly favors to prevent the thromboembolism as compared to the warfarin. In the rocket also it favors the p-value, and as a whole it favors with the oral anticoagulants. In valvular heart disease also, you can see here those valvular mild to moderate valvular heart disease, all apixaban, edoxaban, and higher dose of dabigatran, it favors. But in rivaroxaban, it also favors, but it does not. There was no significant p-values. So if you see about the if you talk about the major bleeding, so in all these direct oral anticoagulants, we can see here that there are it favors with the direct oral content. There were few hemorrhages, except in the rocket trial. We can see in the valvular heart disease there is a more hemorrhage as compared to the warfarin, and those hemorrhages were mainly gastrointestinal hemorrhage, but those were also non-fatal. If we go in the details, those were non-fatal. So as a whole, these direct oral anticoagulants were not inferior to the warfarin, and in some cases it was superior to the warfarin, and there was less hemorrhages as compared to the warfarin. So what is our approach? How to select the patient? If the patient has atrial fibrillation, we will check whether the valvular atrial fibrillation. If yes, then atrial fibrillation with the stroke and shared score is 2 or more than 2. If the valvular heart disease, we will prefer to give warfarin. If it is non-valvular and only patient has the atrial fibrillation, then as Dr. Ani mentioned, that we will go for cardiac management. But if the shared score is 2 and patient is non-valvular, we will go with the oral anticoagulant therapy, and the meanwhile we will assess for the Has-Blood score, and then we will assess patient's clinical status, his value, his financial status, a lot of other things. After that, we will decide that which medication is to be started. So when do we start the medication after the stroke in a patient with atrial fibrillation? So if the patient has atrial fibrillation and he has a big massive stroke with the hemorrhagic transformations, or there is an ICH, then definitely we will not start the anticoagulation. We will do the echo and we will check whether there is a LV clot is there or not. And if there is a LV clot and the patient has the hemorrhage, then in that case we will be stuck, because both scenarios are difficult. So we will discuss with the family and we will weigh the risk versus benefit, and we will wait for some time and then accordingly. But if the patient has a large acute infarctions, blood pressure is also very high, he has a symptomatic hemorrhagic transformation and these things, then in that case also we need to be very careful. But if the patient has a mild to moderate stroke, and then in that case we can think about to start according to the size of the stroke and size of the stroke, or according to the patient clinical conditions, blood pressure and these things. So what is the preference of direct oral anticoagulants? For example, in Asian patients, if you are thinking about more ICH, for example, elderly patients where the chances of the ICH is high and these things, in that case, we can select the apixaban, because chances of ICH is less with the apixaban as compared to the other medications. So even in the apixaban, we can adjust the medicine according to the patient age, patient's body weight, and renal condition also, so this is preferable to start with the apixaban. In the renal impairment patients also, it is preferable to start with the apixaban. Patient with the GI hemorrhage also apixaban and dabigatran, preferably less dose of the dabigatran. If the patient has a high risk of the bleeding after the warfarin, then in that case we can give a high dose of the dabigatran. Recurrent stroke despite the warfarin, we can think about the dabigatran higher dose. If the patient wants that they don't want more dosing like BD dose, then single dose rivaroxaban we can give in those patients. So in summary, if the patient has more chance of the ICH and the elderly patient with the renal function, so in those cases, non-valvular heart disease, we can select the apixaban. If the valvular heart disease, we can select the warfarin. And if the patient has recurrent stroke, even with the warfarin, we can think about the higher dose of dabigatran, 150 milligram. So AHA guidelines came, and it is reviewed in 2021. And here you can see that all level 1A indication that all patients with a non-valvular atrial fibrillation and stroke, TIA, oral anticoagulation is indicated. In the valvular heart disease, better start with the warfarin. In the there is a new thing here that if the patient has a contraindication with the oral anticoagulants or anticoagulation, then you can do percutaneous atrial appendage closure also. This is 2B indications. Similarly, here in valvular heart disease also, in the most of the cases, it's better to start with the warfarin. So for here, you can see this left atrial appendage occlusion may be considered in patient with atrial fibrillation, increased risk of stroke who have contraindication to long-term anticoagulation. But in these cases also, we can give anticoagulation for some time along with this left atrial appendage closure. So in summary, the stroke prevention is not only to give anticoagulation medication, but this is a holistic management of the patients with which can be improved with the patient awareness, is stratification, proper selection of the medications, and then better symptom management with the rate control, rhythm control, then to control the cardiovascular risk factor, comorbidity optimization, including the lifestyle changes of the patient. And we should also understand the patient value and what is the preference of the patient for the medication, their financial status also. These things are also matters. Not only that we decide that this medication, so in most of the cases, we need to discuss with the patient the suitability of the medicine. So here I have few cases, only 3. It will take small. This is our hospital cases. So number 1 is 74-year-old female. She is known case of hypertension and hypothyroidism, and she presented with sudden onset right-sided weakness. She was diagnosed as acute ischemic stroke, and she received the TPA and then went for mechanical thrombectomy. ECG showed atrial fibrillation. We did the echo and it showed LV clot with 25% ejection fraction. So I will show you the CT brain, which is day 2 CT brain here. So here you can see this patient has big stroke here, hypodensity, and there is some hyperdensity area is here. So this is post contrast actually. So there was a discuss between us and radiology, that is contrast versus hemorrhage, and this patient has big stroke in the left cortical area, and this is day 2, and she has atrial fibrillation, low ejection fraction, and at the same time she has the LV clot. So it was challenging for us that what to do now, because if we don't start the medicine, the LV clot will dislodge, and if we start the medicine with this big stroke, then there is a chance of hemorrhage. So this is the problem. So in this case, we have discussed with the family, and then we decided to wait for a few more days, and we repeat the CT scan if there is no new hemorrhage, or if the stroke there is no hemorrhagic transformation, then we preferably start with the heparin, so we can reverse in case of the hemorrhage or any other things. So this is another case. We have 35-year-old male, and he presented with the unresponsiveness, and he was out of the window period, so we didn't offer any intervention. Echo was normal. There was no alveolar ejection fraction. ECG showed paroxysmal run of atrial fibrillation for 2 minutes on day 2 while he was in the stroke unit. So initial ECG was normal, and in the second day it shows the paroxysmal only for 2 minutes, and this is the CT brain. So initially he was only on aspirin, and this is the CT brain on day 4. So you can see here the small hypodensity in the right bones, and there is a bilateral hypodensity in the thalamic area. Actually, this arterioperforan affected, and bilateral minor stroke in the both thalamus as well as in the bones. So this is a day 4 CT scan, and we have the paroxysmal atrial fibrillation. So this is the difference in neurology. If we find even for 30 seconds paroxysmal atrial fibrillation, we give anticoagulation to the patients. And with this size stroke, which is very minor stroke, bilateral, we can start within 3 to 5 days. It is much safer. And the new studies are also, according to new studies also, they are more comfortable to start as early as possible. This is the last case. 67-year-old male. He's a known case of hypertension, diabetes, and ischemic heart disease. Patient was on warfarin, and his INR was therapeutic. He presented with right-sided weakness, and he was in the window period of mechanical thrombectomy. So we did the mechanical thrombectomy. His ECG showed atrial fibrillation. Echo done. There was no LV clot. Patient had bovine mitral valve 3 months ago. So atrial fibrillation with bovine mitral valve 3 months ago, and I will show you the CT brain, which was done on day 14. So this is the CT brain for this patient. Actually, the initial CT brain also shows a hemorrhage, and this CT brain, if you see on day 14, you can see here that there is a massive stroke, and with the hemorrhagic transformation all over. Patient blood pressure was also not well controlled. His GCS was, he was globally aphasic. Clinically also, he was not in good condition. So in this condition, it is very, again, it is very difficult that what to do with this this hemorrhagic transformation. And family, they didn't want to take any risk of hemorrhage. So we decided to wait for a couple of more days and to repeat the CT scan. And then we try to convince the family that if hemorrhage resolve, we will start with the low molecular weight heparin. So these are the timing of anticoagulation. There is no clear-cut guidelines, but with different studies, we can say that AHA said that within 4 to 14 days of post-stroke, we can start with anticoagulation. And European Society says 1-3-6-12 rule. For example, if the TIA, then on day 1, we can start if it is a small size stroke, less than 1 centimeter, minor. So third day, if it is less than 1/3 of the territory, we can start before 1 week. Or if it is more than 1/3 of the territory, then after 2 weeks. Same here in the SO 4, 7, and 14 according to the size of the stroke. Thank you very much.
Okay, thank you very much.
Dr. Thank you. Tfadal, Abdullah.
Okay, so we don't have any questions, so me and Dr. Suhail are gonna entertain, ask you a question, guys. So Dr. Suhail mentioned at the beginning the stroke prevalence, 15 million, 5 dying and other disabled. If we focus on atrial fibrillation, also atrial fibrillation is very common, is about 337 million suffer from this, 0.5% of worldwide. Yani. So Dr. Hani, why patient with atrial fibrillation get the stroke? ما نسمعك. So هاي سماعة ما منها فايدة، شيل السماعة خليك بدون سماعة أحسن.
Why patients with atrial fibrillation develop stroke? There's essentially three things. First of all, the substrate. You know, to develop atrial fibrillation, you have to have some sort of substrate. So in patients who have a dilated left atrium, there's going to be some scarring, fibrosis. Number two, there is going to be reduced filling. There's no contraction of the atrium. The lack of contraction of the atrium, 99% of the time, results in spontaneous echocontrast, what we call on TE smoke that you see within the atrium, and more importantly in the atrial appendage. And then 90% of patients who have an embolic stroke will have something in the left atrial appendage if you detect it at an early enough stage. So it is the stasis as well as the hypercoagulable state that leads to the atrial fibrillation and the associated conditions, Verko's triad, as you know, that leads to stroke. So generally we look for the TE. If a patient has a stroke, we find within the left atrial appendage, most of the time there's something there. And when we do a cardioversion, بالعكس يعني in reverse, if we're looking for a cardioversion, we find that the left atrial appendage contains a thrombus. We cannot do a cardioversion. So this is one of the main stories in patients with Afib. So so I think this is really one of the obvious ways to detect it. If you detect Afib, you have to carefully dissect the patient's substrate. Do they have valvular heart disease? Therefore, they have to have warfarin, anticoagulation. Do they have LVH? Do they have hypertension? Do they have coronary artery disease? Do they have heart failure? Are they diabetic? So diabetes is a primary risk factor in two ways. It increases the risk of stroke in patients with Afib and itself drives the CHA2DS2-VASc score positively. If a patient has had a prior thromboembolic event, so they've had a prior stroke or TIA, or if they've had an embolism into the arteries, into the gut, into the spleen, into the legs, or any other systemic embolization, that changes the CHA2DS2-VASc score.
Maybe I also ask you on that, because patients develop atrial fibrillation. How soon after atrial fibrillation they develop a stroke? Do you have an idea of that? I mean, is it within a day, within hours?
So this is a very interesting thing. In fact, one of the original studies that looked at this was the study that validated the use of the TE. This was called the acute study. It's a very old study from 1980s. So, you know, you can have a stroke even if the patient is paroxysmal Afib, right? So they're in and out of atrial fibrillation. So it doesn't really matter if the patient is currently in Afib. It's actually two things. It's the substrate that creates the thrombogenicity and the stasis, and the presence of Afib together, which is also, to answer the question in a more clear manner, even if the patient's in sinus rhythm, we never stop anticoagulation. Even if the patient has a successful ablation, we will not stop anticoagulation if the CHA2DS2-VASc score stays elevated, right? So I think it is the atrial substrate, the myopathy of the atrium, the thrombogenicity that's created by the underlying disease, that is the thrombotic substrate for the patient. So we have seen patients in paroxysmal Afib, they come to you a week later with a stroke, because once the atrium contracts, this is the problem, right? Once the atrium contracts, the thrombus is pushed out into the systemic circulation. So the presence of sinus rhythm does not protect the patient in stroke if the CHA2DS2-VASc score is elevated.
Dr. Suhail, you want to ask?
Yes, thank you, Dr. Hani. I have a question to Dr. Habib, but before that, I would like to ask Dr. Hani, the warfarin or the NWAC or the direct anticoagulation has been only approved for the atrial fibrillation, but we stick still with the valvular heart disease, with the LVH or poor EF to keep these people on warfarin. Why we don't shift these patients to NWAC and stay with warfarin with the INR follow-up? And because that was much easier when the patient had Afib, just put them on the NWAC. But now with the other quality of patients, we need to keep them on warfarin.
So excellent question. So DOACs are also approved for ventricular, for VTE in general, so PE and DVT. There's been a recent clinical study that was published, the randomized clinical study called the NO-LVT, no-LV thrombus. This was a randomized clinical study that used rivaroxaban in patients with left ventricular thrombus, and there was a significant reduction of bleeding with rivaroxaban compared to warfarin, and a almost 50% reduction in stroke. So I think now the data shifts more also in patients with LV thrombus and heart failure to use DOAC. I think that's a fairly clear indication. So the final one is going to be valvular heart disease. And I know Dr. Habib mentioned it very clearly. Patients with rheumatic heart disease, particularly rheumatic mitral stenosis, cannot receive a DOAC, cannot. It's contraindicated. They have to be on warfarin. Number two, patients with mechanical valves. Mechanical valves, this was the Realign study. The study had to be terminated early. Warfarin is definitely the way to go. So if a patient doesn't have rheumatic mitral disease and does not have a mechanical valve, then the definition is a little bit different. For example, if a patient has a TAVI due to aortic stenosis and develops atrial fibrillation, it's reasonable in this case to give them a DOAC, okay? This is one. Number two, if a patient has a mitral valve regurgitation that is repaired and then develops atrial fibrillation, that we don't anticipate that this is due to rheumatic heart disease. It's myxomatous mitral valve, and in this case, DOAC is also reasonable. So once we say valvular, we are essentially talking about the groups of patients that were excluded from the randomized clinical studies, and those were patients with rheumatic, primarily mitral, but other rheumatic disease. Why? Because rheumatic heart disease, as you all know, is a myocarditis. It's a carditis, right? Pancarditis is one of the hallmarks. So it affects the atrium, it affects the ventricle, it affects the endothelium, it affects the valves. It's a different scenario. And we have seen, I'm sure you have seen many patients with mitral stenosis in sinus rhythm because of the huge left atrium develop a stroke. So I think this is one of the differentiating words in the word valvular. Valvular in this day and age, I believe, means mechanical valves of any kind, any position. Number two, rheumatic, particularly mitral, but also other diseases. Now, all other kinds of valvular heart disease, sclerotic aortic valve disease, calcific aortic valve disease, mitral valve repair due to myxomatous mitral valve doesn't fall into that category. And as Dr. Habib showed in the apixaban studies, there was about 19% of patients with aortic disease that were included. So we have to be very careful about the definition. And this is why, you know, the management between the cardiologist and the neurologist is essential in these individual cases.
Very interesting, update in that field. Dr. Habib, we know that from our experience that almost 25% to 30% of the patient who's coming with a stroke is coming with what we call it cryptogenic stroke. Is there anything that we can add to these patients to find if they are having a proximal atrial fibrillation, and what's your practice in that field?
Yeah, so this is very interesting, and we are facing this problem because we have a lot of young patients in our hospital, and then after this, all investigations, these are negative. For example, even if we do the TE, Holter, ECG, everything is negative. But if you look radiologically, this stroke looks like more cardioembolic. For example, sometimes we see showering, sometimes we see more cortical stroke, which goes more in the favor of the cardioembolic source. In those cases, what we do, that we repeat the Holter maybe after 1 week, or then after 2 weeks. Or there is a study, ISAS trial, I think, and that also showed that if we start with some anticoagulations which have less chance of the hemorrhage, then that may be better than aspirin.
Dr. Hani, in these patients that Dr. Habib spoke with them, that we will do the routine stroke workup, including the transthoracic, transesophageal, we will do the bubble study, plus doing the Holter for 48 hours or 72 hours. Is there any evidence of doing more prolonged cardiac monitor in these patients, and what the high yield of doing a longer, and what the evidence?
Sure. Thank you very much. An excellent approach. So I think what has been shown in these patients with cryptogenic stroke, that empiric anticoagulation, while it may reduce the risk of stroke slightly, it offsets by increased bleeding. So what is the current, at least recommendation from the American College of Cardiology, is the implantation of an implantable loop recorder. So an implantable loop recorder was based on the Crystal AF study. So the device is implanted. It's a very simple thing. It's like a microchip. You implant it under the skin with remote monitoring capability. It can monitor the patient for at least 2.5 years. And this was shown to increase the detection of atrial fibrillation over the next 2.5 years by at least 60% more, right? So the yield is higher in these patients. And this then allows you to safely initiate anticoagulation right off the bat. The benefit of these devices is that they are coupled to a remote monitor. In fact, they transmit through a cell phone to a base station so that we get notification in the hospital or the clinic. I mean, we've had this system set up for almost 4 years now. Immediately, almost as soon as the patient gets atrial fibrillation, you can detect it. Now, there's an alternative approach, which is even much cheaper and commercially available. And I'm not going to make a pitch for Apple, but Apple Watch has an FDA-approved algorithm, which includes an ECG with automated AF detection. And this was part of a gigantic clinical study. There were 600,000 patients where the device was allowed to detect Afib automatically and then confirmed by physicians. And this allowed the FDA to approve this algorithm. So in fact, if you don't want to implant an implantable loop recorder, if the patient has a smartwatch with the Afib algorithm implanted, and I know that now Samsung has come up with an FDA-approved one. So this will automatically detect Afib, flag it on the phone and tell the patient and warn them, look, you have atrial fibrillation, go and see your doctor. So this is becoming commercially available. In fact, one of the biggest insurance companies in the United States called Aetna US Healthcare has taken a step about 3 years ago to issue all of its members a free Apple Watch in order to detect Afib, because they monitor patients, they have patients who are above 65 years old and the risk of stroke is high. So it's actually a very cost-effective way to detect atrial fibrillation and make the treatment accordingly. Unfortunately, the yield of a 24-hour, 48-hour, 72-hour, 7-day monitor is still very low. And in the acute phase, you're not going to really pick up much. So I think this is it. But this is how the technology is evolving to help us detect and prevent stroke.
Thank you, Hani. Abdullah.
Hani, with the antiarrhythmic medication and then the device introduction. I mean, is it now we kind of prioritize devices to start first line atrial fibrillation, and does that help preventing stroke?
Device in terms of remote monitoring or ablation, yeah. So the 2019 guidelines were suggesting at least one antiarrhythmic, including either beta blocker or calcium channel blocker, prior to ablation. Now, as we know that the success rates have increased, the safety has improved, this becomes a patient-physician discussion. In my clinical practice, if a patient is young, symptomatic atrial fibrillation, they are not tolerant of beta blocker, it becomes very challenging to tell them, let's wait another 6 months, take another antiarrhythmic, let's do an Afib ablation, right? The other side is not the same. I have a 70-year-old patient who's not very symptomatic, doesn't really have heart failure. They get some episodes of Afib. We can try them on amiodarone. We can try them on flecainide. Maybe I'll defer for 6 months. But so these become individualized discussions, because in the guidelines now we have established the safety of early ablation. We have seen the efficacy. We are saying that the recurrence rates are in the order of 15%, success rates of 80%. But there is one thing that we can modify in all patients. That is sleep apnea. Okay, sleep apnea contributes to 40% of recurrences in patients with Afib ablation, 40%. So one of the things we actually insist on, if a young patient comes to us who's overweight, BMI is above 30, the Epworth sleep score is above 12, stop bank score is positive for likelihood of sleep apnea, then we send them for the sleep study. We make them correct this. We tell them to lose weight, because we know that that's the kind of patient with metabolic syndrome and obesity-related atrial fibrillation who is likely to have recurrence regardless of ablation, right? So I hope I've sort of answered it. It's more like an individualized approach, but early ablation is recommended more. We have, unfortunately, a lot of young people So I think we can help them a lot by doing ablation. And I think the success rates in the UAE are the same as internationally.
And that's important because, again, ablation need to be, again, as you know, is volume
dependent.
Yeah,
Yes.
I mean, we don't want to send patient just for, to any place. My questions to Dr. Sayed. Now, we're focusing on atrial fibrillation and stroke, fighting a stroke, but treating atrial fibrillation causes stroke because of this NOACs or warfarin. How you manage these patients initially, then later on? Will you go back on another anticoagulation, or what do you do?
Sorry, I didn't get the stroke patients who are already on the NOACs and atrial or warfarin, and they developed another stroke, you mean?
Yeah, the patient, if they're on NOACs or warfarin, they're at risk of getting, bleeding, stroke, that kind of stroke. I mean, how you manage this initially, then
Yes.
later on, will you change them to another NOACs to prevent ischemic stroke in future?
Yeah, very good. So actually, these patients, once they come, they are already on the warfarin or any NOACs. So of course, if their INR is not in the therapeutic level, we don't consider for any IV thrombolysis and these things. This is in the acute setup. Or if the patient is on NOACs, then at least 48 hours apart from this stroke should be there. If the patient received the NOACs within 48 hours, we don't consider any IV thrombolysis. Then later on, we assess that.
Okay, fine. No, so you answered another question, which is good.
Yeah, I'm just coming to.
My question was the bleeding one.
Yes, so I'm coming to your question. Then we assess that these patients who are on the NOACs and whether they were compliant to their medications, or if their INR was therapeutic or not therapeutic. But usually, if the patient is on warfarin, we don't switch. But the paper says that if we can switch also, if the patient have recurrent stroke and he's on warfarin, we can switch on a higher dose of the dabigatran. But clinically, we did not do any. I'm not aware of any such patient where we have shifted on higher dose of dabigatran if the patient had recurrent stroke even on the therapeutic dose of the warfarin.
Dr. Sohail.
Yes, so the question is regarding ICH bleed for a patient on anticoagulation.
Yes.
Look, this is very challenging case when you will start these patients. First, number one is it traumatic, non-traumatic? Okay, if it was a spontaneous intraventricular or intracranial bleed, definitely patients need to stop the anticoagulation. First, it depends how big is the bleed, but minimum for 4 weeks, these patients should be off anticoagulation, especially in the elderly people. That's number one. Number two, if patient was on warfarin and his INR was supratherapeutic above 3, definitely that need to be reviewed if he need to be on warfarin. If patient was on warfarin, then he bled, definitely this patient will be changed to one of the NOAC. Most likely he will go to apixaban or rivaroxaban. Number 4, looking for the age of the patient, if he's in the same category below age of 80 or 85, and if he need to be on the smaller dose, which is 2.5 for apixaban or 15 milligram for rivaroxaban. It's always a debate to put a patient, but at least in this condition, if patient was stable, I will keep him 2 to 4 weeks of anticoagulation. The question will come now if the patient's echo showed that patient is on anticoagulation and at the same time he has intraventricular or left atrium clot. That will be a huge challenge because patient has a bleed, and at the same time, he has a high risk of ischemic stroke because of that clot which is sitting in the heart. So usually we will keep patients off anticoagulation, restart him when he's stable, maybe day 5, day 6 on heparin or sub-Q Clexane, smaller dose tapering going up. So it's case by case, looking for different things for these patients, but there's no 100% rule when to restart and what to start them on.
Great to hear that, and that was comprehensive answer to, I think, very common practical questions. We are attendees 219. This is live with us until now, but I think they're enjoying the questions from both of us and answer from the speakers and yourself.
I have the questions to Dr. Habib. Dr. Habib, during our practice, we noticed that the presentation of ischemic stroke due to cardiac source, their presentation usually is different from other types of stroke, like large vessel disease or small vessel disease or lacunar stroke. Can you tell us more about this here?
Yeah. So yeah, in the emergency, if the patient present with the stroke, the cardioembolic patients, they behave differently. For example, we have seen more in the younger populations in the cardioembolic stroke. They have some history of the heart disease, and they present with mainly the cortical type of the strokes. For example, they will have the big stroke, their NIHSS, their weakness and these things will be more as compared to the small vessel disease or carotid disease. There will be cortical signs. For example, if it is a left sided stroke, there will be aphasia, there will be field cut, and there will be neglect and these things. So these things go more in the favor of the cardioembolic strokes. And then later on, we do all other investigations to find out the source of paroxysmal atrial fibrillation or these things. But in the small vessel disease, we don't see the cortical signs. For example, aphasia, we don't see much aphasia or neglect or these things. So this is how we can differentiate clinically in the emergency directly.
Thank you, Dr. Habib. Dr. Hani, before we ended, I have this question. Always we have with the stroke specialists, when we are doing more frequent the mechanical thrombectomy, doing the aspiration or the stent retriever, and we will see different picture of thrombi or when it's retrieved. We will see the white one, we will see the red clot retrieve, and we will see the mixed one. From cardiac input, do you see this also with the atrial fibrillation or other disease, the white, the red, the mixed color one?
So I imagine this is related to the duration of the thrombus formation. Right, so it's typically a stage of the thrombotic process. I don't really have any personal experience with mechanical thrombectomy. I mean, we generally are leaving that to our interventional neuroradiologists, and then we take care of these patients afterwards. It would be interesting to look at the content of these thrombi, but I think the main concept that I think is being seen here is that the thrombus can form at any time. It is accumulating within the left atrial appendage, and then it's propelled into the systemic circulation, either randomly or when the patient goes back into sinus rhythm. Right? And then why does it go into the cerebral vessels, and maybe it goes into the splenic vessels sometimes, and sometimes we have other systemic embolization. So it's literally a matter of the duration of thrombosis rather than atherosclerosis. I mean, in the coronary arteries, it's a different story. It's a plaque rupture. So the plaque ruptures, and then a thrombotic event acts to fill the lumen, right? So when we're doing the stent or the PCI, the objective here is to extract whatever thrombus is there, but we also apply a stent to the blood vessel wall, because this is an atherothrombotic process rather than a cardioembolic process. So I don't know if I can answer your question in a scientific manner.
And when you are doing this with the cardiac, with the rupture plaque, if you aspirate it, which color that will be?
So Dr. Abdullah Shab, of course, is an interventional cardiologist.
Why I'm saying that?
Usually a fresh clot.
Yeah, usually with the cardiac, as you said, it will be days or weeks that clot has been there, and usually it's full of RBC, full of fibrinogen, compared to the carotid or artery to artery plaque rupture, which will be mainly platelet aggregation, and it will be more whiter compared to the cardiac one. So for that, usually we believe that the dark red one is a cardiac one, and fresh platelet will be the whitish one. But that's still, there's one clinical trial is ongoing for more than 4,000 patients, and maybe it will be published soon, looking for the stent retriever and mechanical thrombectomy, looking if that can help us also to decide from where that occlusion came. Is it large vessel disease versus and cardiac sources? Abdullah.
Great, thank you very much. You guys, I think we covered everything about fibrillation, so we went outside now. I mean, we have as plaque rupture, which is steel elevation, you know, that's where you get a fresh retrieval, and that looks red to us. I mean, the non-steel elevation, of course, which we don't know. I mean, this is very difficult to retrieve that, but again, we are learning. So people call it white. I don't know. I'm not sure, but it's not happening. So I'd like to thank at the end Dr. Sohail from Neurology, President, and myself. I need to thank myself as well. And then the two speakers, Dr. Sayed and Dr. Hani, for great effort into this. Outstanding, mashallah. I think we covered everything to do with our clinical practice. And also not to forget the ICOM managing this meeting. Dr. Sohail, you want to say something?
Yes, at the end, I'd like to thank both of our speakers. I would like to thank ICOM and Pfizer for sponsoring this event. Thank you again.
Yalla, take care. Assalamu alaikum.
Thank you.
Assalamu alaikum, Dr. Hani. Assalamu alaikum, Dr. Habib. All delegates. Assalamu alaikum.
Assalamu alaikum.
Thank you, Viad. Thank you.
Thank you.